I can't take it apart. It's too dense. I did too good a job of healing it. I have to wonder what your practice would have been like if you had known about the vestibular diagnoses, how to test for it, how common it is. One thing I did find out at Cleveland Clinic was I couldn't treat microcephaly. Frozen shoulder doesn't come from space. So I basically put 9 machines on it. When it comes to Ehlers-Danlos or even hypermobility syndrome, it's the connective tissue that is defective.
Thank you for subscribing to the Frequency Specific Microcurrent podcast. FSM is a breakthrough tool for medical practitioners who feel stuck with limited treatment options, especially for complex issues unresponsive to conventional care. FSM training is the best continuing education course for medical practitioners. Get our free introductory webinar at frequencyspecific.com/about or find FSM trained practitioners at frequencyspecific.com/find. Here's Dr. Carolyn Pittis.
Hi guys, who's here? Michelle. Hi Alice. Cindy. Jenny's note taker. Kate. Hi Kate. Kathleen Casman, how are you? Hi Leaf. Madeline. Maria. Marion. Michelle. Ronnie. Steve. Susan. And Wendy. Cool. It's nice to know the family. Back to me and Kevin. And now get these guys over there. It was Canada Day, so you were up in Canada. That's pretty cool. So Kim is on an airplane today, which is why I'm all by myself. Dave had company and Ben was working. So it's just us. And I'll have had some interesting patients this week. We'll talk about that. But let's look at, that means you guys get to ask questions, which will be really fun. Michelle, floppy baby syndrome, not walking or talking yet. And is that the same as a 21-month-old baby diagnosed with hypotonia? Michelle, are those the same creature? Same child? I think. Pretty sure. I would have to Google what causes floppy baby syndrome. That's a good thing to check, huh? Floppy. This is what I do in the clinic, actually. So the question is it a mitochondrial disorder or is it neurologic? Okay, same baby. Anytime. So that's the question, Michelle, is where does it come from? Let me look on my laptop. Because this is what I do in the clinic. You look up what causes it. Is it a mitochondrial dysfunction? Or is it something in the brain? Brain or nervous system disorders, lack of oxygen, brain malformations, genetic metabolic disorders, damage or diseases affecting the nerves that control the muscles, various muscular dystrophies. I'm reading it from Kevin's computer. Spinal muscular atrophy. Ooh. SMA is difficult. SMA is something we have treated before. And, oh, what was her name? I can see her face, so I can't. I think she's a naturopath from Pennsylvania. She treated SMA. I treated one SMA patient, 2 SMA patients. One of them was successful. The other one was not. It is a genetic defect in one of the genes in the spinal cord that does motor conductivity. Very happy, socially aware, sounds like SM. And oh, I can see her face. What the name? I'll look it up. A very nice practitioner, one of the instructors, as a matter of fact. Anyway, she did 528 for repairing DNA in the spinal cord, and I would suggest doing the mitochondria. And that was the case that I saw this week that I thought would be worth sharing. And that is a patient with another genetic disorder called SPG7. It is a genetic disorder that affects the mitochondria and creates misfolded proteins in the motor pathways in the spinal cord. What's interesting is she was completely normal until she was 38. And what set it off, we think, was COVID. So this week she responds really well to 528 in the mitochondria, since it's a mitochondrial disorder. She also responded really well to the viruses in the mitochondria. So 38, 41, 44, 56, 160 in the mitochondria, 543. The little I is going to probably go away from that. It's the mitochondria as a whole. And then down on this list, towards the bottom, is mitochondrial DNA. And the list, George's experimental list for mitochondria, was something I blew off because of the way he found it. But it actually worked, at least with mitochondrial DNA, 641 as that. And so we'll have that on the list for next year. And so you could try 120 misfolded proteins or protein excess and 528 repairing DNA in the mitochondria, 543 spinal cord. And I think that's what name almost came out of my mouth. What? If you're listening, tell me your name. I can see your face. Christine Allcroft. Thank you. She's not on the screen. It's just popped into my head. Postmenopausal brain is like a magic 8-ball. If you just wait long enough, the name comes back up. Anyway, so she treated an SMA patient, and the baby went from not being able to sit up to being able to sit up and play at a sitting table. So that would be worth trying. Can't hurt, might help. This may be a dumb question. No dumb questions. Clarification about avoiding 1351 for 6 weeks after an injury. Curious about the gray areas of injury rather than the obvious injury. What are gray areas of injury? What's the criteria? What informed this precaution timeline? Empirical. It was practice, reality. Fell on your butt about 1 foot from the ground, no pain or bruising. Yes, Michelle, it was an SMA patient. It's one of the most common causes, I think, of floppy baby or hypotonia. That's a tough one. It is very difficult. Anyway, fall on the butt, that's from ground with no pain or bruising. Okay. Yeah, I probably wouldn't worry about that. If there's no pain or bruising, then no, that's not a new injury because they just fell. So a new injury is when you're injured. Cut on a finger, that's avoid 13. until it's done. And right now I'm playing around weights. A lot of my mileage comes from stuff that happened to me. I had surgery here to loosen this tendon. Now, granted, the surgeon didn't quite do it right. He did not do plastics, so the scar cuts across the folds in my hand. But I ran postoperative healing, and the skin and connective tissue grew over the stitches. And now there's scar tissue even I can't pull apart. So there's going to be another surgery involved that has to be done by a, hi, Eleanor. It's a baby. Yes. Has to redo the scar tissue. I can't take it apart. It's too dense. I did too good a job of healing it. So if there's a cut to the finger and you're trying to heal it, you want to avoid scarring, taking out the scar tissue, 13 and 51, until the cut is repaired. If there's no pain or bruising, then do you have a new injury? No, you just fell on your butt. So, Suzanne, that's not actually a dumb question. It's empirical, right? That's the empirical part of it was, Ellie, come on. Thank you. The empirical part of it was having a patient with a sprained ankle, and the practitioner had a sprained ankle, and she started working on scar tissue in a patient, no contact with her ankle, but she just used her hands to deal with scar tissue in a patient, and her ankle got worse. So we learned it kind of the hard way through just mileage. That's just how that went. So how you guys have to have other questions. You got what I got, which was the two mitochondria frequencies. One is mitochondria 543, and one is mitochondrial DNA. The other thing I did yesterday was present our vestibular section to a group of senior or junior chiropractic students. And I have to wonder what your practice would have been like if you had known about the vestibular diagnoses, how to test for it, how common it is. It's 20%. At least it's 20% of every class. It's about 20% of our practice, as is hypermobility. It's more common in hypermobile patients. And what symptoms to look for. So in the history, it's phrases like, you go looking for a vestibular injury if you, like me, don't automatically do a vestibular screen on everybody. The hints are, I'm clumsy, I have an anxiety disorder, I have trouble sleeping, I'm a terrible reader, always have been, or I've been really anxious and sound sensitive since the auto accident, head injury, fall, whatever. Go looking for, or at least do the screening exam and have them fill out the BIVSS. Suzanne, have I ever treated a charge, CHARGE syndrome? I assume it's babies, is a complex genetic disorder caused by mutations in the CHD7 gene. I don't know what gene that is. Kevin, can you look up CHD7?
Sure.
It affects approximately 1 in 10,000 or 15,000 babies worldwide. The name is an acronym for the most common characteristic features: coloboma, eye defects, heart defects, atresia of, the openings in the nose, retarded growth or development, genital abnormalities, and ear abnormalities. Haven't seen the client yet, but you have a 14-year-old client that has only one vestibular cochlear nerve. So I'm looking up on Kevin's computer, though not everyone says full syndrome. So it sounds like there are multiple genes involved. The range of symptoms is now often referred to as CHD7 because it exists on a spectrum. It sounds like there are multiple genes involved: eye, heart, hearing, balance, swallowing, feeding, low muscle tone, developmental delayed puberty or genital abnormalities, loss or reduction of the sense of smell. No, I've never treated it. I guess the question is the gene, given what it affects. So hearing, heart, eye, hearing and eye and balance and swallowing point to the medulla and the pons. Genital abnormalities, that isn't related to the pons. No, I've never heard of it. I've never treated it. I imagine if I spent more time at Cleveland Clinic, I would have had a chance. But the one thing I did find out at Cleveland Clinic was I couldn't treat microcephaly, the disorder that was caused, I think, by some sort of mosquito bite, where the baby is born without a cortex, and it didn't go well, and I got nothing. I could produce no change whatsoever. So I don't know. I would treat the pons at least for 528. It doesn't sound like a mitochondrial defect, although you could check what these genes affect. Everything that was mentioned about it had to do with the pons, those cranial nerves, except for the genital defects. I did have one this week that is much more relevant than these really rare things, and that was somebody that got an instant frozen shoulder. And I went, oh, my response was, what did you do? Nothing. The weekend before, I did a little raking, and then on my left shoulder, I held the blower, and on the right shoulder, I just did a little back and forth with the blower tip. And 1 week later, I woke up and could not move my right arm, just couldn't move it. And so frozen shoulder was the diagnosis. Pain level was a 7 or an 8, couldn't move it at all. Had about 10 degrees of motion in the abduction, couldn't move the biceps, and resisted external rotation. Yeah, resisted external rotation was a big deal. And it's like frozen shoulder doesn't come from space. So I basically put 9 machines on her. Concussion protocol, and on the shoulder, torn and broken, and the round tendon, supraspinatus, because she couldn't abduct it. I wasn't about to put my fingertips in her subscap, too sore for that. Couldn't She couldn't even lay down. We had to treat her sitting up. And torn and broken in the round tendon, torn in another machine, torn and broken in, or 124, torn and broken in the connective tissue, inflammation in the bursa, inflammation in the immune system, torn and broken in the labrum, inflammation in the cartilage, torn and broken in the joint capsule. I think there were 9 machines on her. And then she already had a CustomCare. So as I went to program her CustomCare with the shoulder injury protocol and extend some time, so I took the shoulder injury protocol, modified the times to increase them because she had a converter. And I said, that you run this twice at night because it got to be about 4.5 hours long. And once or twice in the daytime, because frozen shoulder doesn't come from space. It usually comes from some injury. And yes, Alice, frozen shoulder is how I found me. You found me. Yeah, it's not that hard. It always comes from someplace. When I went, and you have to understand, once a patient leaves the office, everything about them just falls out of my brain. So you have to take good chart notes. So when I went to reprogram her CustomCare, I noticed that she had Ehlers-Danlos. She was hypermobile. And I went, oh, well, that's how you could get a partial thickness tear just moving the little wand on the blower. And why didn't it show up for a week? It takes time for that tendon tear, partial micro tears, let's call it, to create abnormal shoulder mechanics, make things bump around, irritate and fray the labrum, and make everything inflamed. And it was her hypermobility that got the tendon torn in the first place. And it's like, okay, you don't get to do that anymore. Do what? You don't get to have your arm out with any weight on it because your tendons are stretchy. And when you put weight on them, they have a tendency to get a little shredded. So that was that. I also ran 40 and 116, reduce inflammation in general, because eventually the immune system does get activated. Originally, partial thickness tear causes the tendon, the tenocyte, to express the genes for inflammation, and that starts the cascade. And eventually, I think the immune system does get activated. So we ran inflammation in the bursa and inflammation in the immune system, concussion in vagus. Yeah, that was the frozen shoulder story for the week. Yeah, you guys have got to ask questions. Help me out here. Don't leave me alone like this. We have another 30 minutes, 34 minutes. It's easier to talk when I have Kim's stories to fill in. The other patient I had this week was a patient who described feeling buzzy inside, no tremor on the outside. And she's living in Mexico, and they used pesticides to kill the scorpions and the ants in her house in Ensenada. That's a thing. And she said, I feel buzzy inside. Okay, like I'm getting electrocuted. And hold that thought. Let me finish the buzzy patient story, Suzanne. And part of it was emotional. And I say that because her timeline didn't include the pesticides and Ensenada. It included her mother didn't love her. She didn't get any oxytocin. The people were mean to her in high school. She was married to a not nice man. And then this happened and that happened. And so concussion in Vegas, a lot of time on 40 and 89. But also if toxicity in the spinal cord and toxicity in the midbrain, I tried that the first day, didn't do much. But there are 6 frequencies listed for poisons. And that in the midbrain and the spinal cord on the second day took care of the buzzy feeling, the emotional protocols, concussion in Vegas, and I think I ran TTH 3 times on her. And then we had a discussion about keeping her energy to herself. Those of you that have done the master class have seen this done a couple of times. And so that was another interesting thing. Okay, Suzanne, I have an EDS client I believe may have symptoms consistent with femoral head ligament injury, not diagnosis, no LMT. Observations that would make sense based on not having an injury. I'm not sure what the femoral head ligament is. I'm thinking necrosis is important. Other suggestions, and why in the EDS protocols do we not run 124 and 100 as part of the regular prescribed treatment in addition to 124 and 77? Those are good questions. When it comes to Ehlers-Danlos or even hypermobility syndrome, it's the connective tissue that is defective. It has the defective genes. There's 5 or 6 genes involved in how the connective tissue is put together. I've tried 124 and 100, even on the SI joints, because technically that connective tissue that runs from bone to bone should be a ligament, but 124 and 100 doesn't work. So 124 and 77 does work. So this was purely empirical. We've tried both. 124 and 77 works. That's the thing to remember about FSM, is that it is largely empirical. We try it and then report what works and pass it on. Femoral head, I'm not sure what the femoral head ligament is. The labrum in the femoral head is more of a problem. So I'd run 124 in the labrum. The labrum tends to get beat up if the patient is hypermobile. Holds the femur into the acetabulum, yeah, but so does the labrum. So you can treat torn and broken in the ligament, but I would be inclined to try torn and broken in the labrum, 214 in the hip. Necrosis is important mostly in tissues that lose vascular supply. I use it. I treated a radiation fibrosis patient this last week, and 54 is the frequency for radiation that kills stuff and causes scar tissue, but it also is the frequency for necrosis. Yeah, I'd go for the labrum, Suzanne. Try 214. Intractable spondylolisthesis. Oh, 80-year-old female, Lymph. I'm assuming this was diagnosed with a standing lumbar x-ray. Spondylolisthesis. Do you mean that one vertebra slides forward on the other in the lumbar spine? That is oftentimes from degeneration in the posterior joints that shoves one forward on the other. You can also have a pars defect where the part of the vertebra that holds the facet joints to the body of the vertebra? Yes, to the x-ray. So the pars is intact and it just slides forward. You treat them on their back. Spondylolisthesis tends to slide forward, and it usually has to do with posture and arthritis and getting them to lay on their back and repairing the ligaments and connective tissue that hold it posterior. It's posture, getting an 80-year-old to retrain her abdominal muscles so that it shoves that vertebra back. Treat facets. If the facets are shoving it forward, getting her to do abdominal muscle exercises. That would be and then treat facets. It depends on how far forward it goes. It's usually measured in quarters. So 25% is 1/4 of the vertebra hanging off the front of the one below it, 50%, 75%. By the time they get to 75%, it's usually surgical. They just fuse it from the back or they do a 360 fusion. Nobody's going to be too thrilled about doing that on an 80-year-old female. It's tricky. So they're going to want to try conservative measures first, and that includes you. So treat the facets, have her strengthen her abs, torn and broken in the connective tissue, torn and broken in the disc annulus, because you can't, if you have two vertebrae on top of each other and one of them is sliding forward, if the disc annulus is attached to the bottom of this vertebra and attached to the top of that vertebra, if the disc was intact, it wouldn't let them slide. So maybe torn and broken in the annulus, and have her treat herself at night while she is supine. That's my best guess. And is the problem pain or leg pain or back pain? Usually with a spondy, it'll be back pain until it's leg pain. When the nerves get stretched and they get nerve pain down their legs. Alf, how nice that you're here. What are your suggestions for enhancing lymphatic drainage? Okay. 40 and 50 and 49 and 124. So what is wrong with the lymphatics? Well, they're congested. Why are they congested? They're scarred. They might be inflamed, so they might be scarred. 13. They might be inflamed. 40. They might be congested, and depends on where the lymph needs help. So if you're talking about there was a lecture in England on lymphatic drainage coming out of the skull. So then you would be talking about scarring in the dura, scarring in the arachnoid, and mobilizing the spine and the dura and the lymphatics and the arachnoid. Vascular circulation in the extremities, it depends on what's messing them up. When did it start? What is their blood sugar? What's the blood pressure? Vitality, torn and broken in what? The arteries, the veins, the lymphatics. And I run that usually at least for the lower extremities, from the low back or around the neck even, and then do upward lymphatic drainage, which is light touch. Although as you're running scarring in the lymphatics, you can use more pressure than they use in manual lymph drainage. And then vitality in the arteries, the veins. We've had a lot of conversation about the lymph, about the vascular health following COVID and COVID vaccines. So find out if they had vascular problems before COVID. That's a good question. So did they have vascular problems before COVID? If the answer is no, then try 38, 41, 44, 56, 160, 189. Inflammation, increased secretions, and vitality in the arteries, the endothelium. We don't have a frequency for the endothelium, just the arteries. And then vascular return in the extremities depends on telling the patient get their feet up. Are they sitting a lot? Put their feet up on a step stool or a hassock or one of those thingies. And otherwise tell them to take a walk or set a clock, set an alarm, and every 30 minutes do 10 pumps with their ankles and their feet, even if they're not able to walk because of hip or back pain. That would be my thing. The thing with the lymph is muscle contractions move the lymph in the extremities. So you want to contract the muscles by getting them to move, to take. Oh, thank you for sending a heart. That's adorable. I appreciate it. The lymphatics have no connective tissue. It is connective tissue, but it's not contractile. It depends on the movement of the muscles to move the lymph up. Also the heart, there's that pump, that movement in the arteries. And that's important. Does that answer your question, Alf? Judith, do you think there's any difference in strength of treatment or how it works? Thank you, Alf. I'm glad it worked. How well it works between using the magnetic converter versus wet towels or sticky pads? Aside from treating my face with sticky pads, do you think I have patients that treat themselves at home with the converter. I don't use the converter in the office. And I don't know if my results have anything to do with the fact that I use wet towels. The wet towels allow me to use 10 machines on one patient in 3 different locations: neck to feet, neck to abdomen, low back to feet. The other thing with the magnetic converter in the office, the reason I don't use it in the office is it's weird enough to use frequencies you can't hear and current you can't feel out using something that has blinky lights. So I just can't go there. It's strange enough to be a chiropractor who talks to patients about blood pressure and medication, and I'm not a regular chiropractor. Difference in strength of treatment? Probably not. I even use the converter to treat nerves, especially at night, especially at home. I get nerve pain in my right hand. I have carpal tunnel. And if it lights up at night for whatever reason, I'll put one puck here, one puck in my right hand, and I have a protocol that just says 40 through 96 alternating, and punch a button, 10 minutes, pain in my hand is gone. I go back to sleep. So there's that. Okay, Suzanne, I had done scar work and hardening with somebody in the hand tendons, both hands. There was a significant lymphedema in the left as she had double mastectomy. Yeah, that'll do it. 6 months earlier, one lymph node removed that side and was prone. Okay. I was surprised by this, and then the next day she complained of pain and immobility in the left hand. She didn't recognize it was lymphedema. We got the fluid out. She put on compression sleeve. While treating her prone, she was prone to lymphedema anyway. And yeah, double mastectomy 6 months earlier. That also means that she had radiation and chemo. Only one lymph node removed. That's pretty cool. The left hand tritum supine run from the neck to the hand. No radiation and just chemo. That's unusual. If they took out one lymph node, that's interesting. One lymph node on the left and was prone to lymphedema before the surgery, Suzanne? Wait, pain and immobility in the left hand, she didn't recognize it was lymphedema. Wouldn't the swelling have given her a clue? We got the fluid out, yes, and she put on a compression sleeve, yes, which she should have been wearing anyway. You were wondering what might be the case. Scarring and hardening in the hand tendons on both hands. Well, when you get the scarring out, maybe in the connective tissue without treating the lymphedema, if the lymphedema is a problem and now there's more room. So if you've gotten the if you've gotten the connective tissue and the scar tissue and the interstitium loose, there's more room for the fluid to accumulate, would be my best guess. And then the next day, the lymphatics just had more space to accumulate fluid. And she wasn't wearing her sleeve. Hello. She should have been wearing it the whole time. And I'm wondering why we were doing scarring and hardening in the hand tendons on both hands. And did she not have lymphedema when you saw her? And the lymphedema didn't show up until the next day? Is that kind of what we're talking about? That's interesting. But that's my best guess, is by treating the scar tissue, you made room for more the lymphatics to expand and collect fluid. And then that's what they did. So she had swelling and pain, immobility. It's not that she couldn't move it, it was super puffy. And so you treat the lymphedema and push the fluid back up, and then she puts her sleeve on and the lymphedema goes down. That would be my guess. I wonder why she had hardening and scarring in the tendons in both hands. Where'd that come from? Was her presenting complaint? Was I have hardening and scarring in both hands? That would be a thing. Okay. Wow. That's pretty cool. I got 10 more minutes.
A few more questions.
We do? We're good.
No, I'm seeing over here on this screen.
Okay.
On my
Kevin's got them.
Yeah.
A new client coming in for Achilles tendonitis has been on everolimus and prednisone for what? Okay, so she's been on immune suppressants and prednisone for 26 years following a kidney transplant. No contraindications or safety concerns treating the Achilles tendonitis, whoever that is. It's from
Alice Dicey.
Huh?
Alice Dicey.
Alice
Dicey, remember her?
Dicey?
Dicey with a G.
Dicey. Oh, okay. Hi, Alice. Yeah, no, there's no safety concerns, but duh, she's on steroids. So Achilles tendonitis, just run 124 and 191, torn or broken in the tendon, and torn or broken in the connective tissue because the Achilles is a round tendon, but I'm going to guess, and this is what I found in my SPG7 patient, there's spasticity. She has foot drop, but it's really because of spasticity in the gastroc and the soleus, and that forces her toe down. And that creates a tendinopathy in the flat tendons in the gastroc and the soleus. So treat both 124 and 191, 124 and 77. And in this particular patient, because she's been on steroids for so long, warn her that this is not a one visit fix, that this is twice a week for 4 to 6 weeks, if she's lucky. And when she goes to bed at night, she is to put a pillow at the bottom of her, where her feet are, and her feet are to be at 90 degrees. And that's what they did to me that's what Kathleen told me to do when I had Achilles tendinopathy. But steroids tend to weaken connective tissue. So no, there shouldn't be any problem at all. Just stay away from inflammation. You don't want to treat inflammation, especially not 40 and 116. Thank you for your podcast. You're welcome. And your work. My pleasure. Thank you. I wanted to ask a question. I've been working with FSM for 2 years, and when I use gloves, I see more results than when I use wet towels. What's the reason? I don't know. We gave up using gloves because you have to keep them wet all the time, and that means you have to take your hands off the patient. The wet towels conduct, we know that for sure. It was George's idea to use wet towels, and I resisted for 6 months, maybe a year. And then finally it was like, duh. And it just allows more coverage and allows us to use more machines so we can multitask and do more and get more done. I don't know why you get more. I'm not sure what you mean by more results. Do you feel? The one thing with the gloves is you can feel when they get hot. For me, what I've learned to feel for is smush in the forearm. I use the forearm flexor wad. You can use any muscle that gets squishy, but the forearm flexor wad in most people just doesn't have much tone, and it just goes smush when the frequency is correct. So that's how I can tell that it's working. So it could be that the gloves give you better feedback about what's working because they get warm, they get hot. With wet towels, you have to feel for smush, and that is a little trickier. So maybe that's it. And so you have better feedback with the gloves. And so you are able to modify your choices more effectively. That's a rough guess. There we go. Love your method and your page. I'm an acupuncturist. Will train with you in the near future, but must correct you on something here. Lung is not the mother of the spleen. Fire is the mother of the spleen. Well, it depends on who you talk to. People that told me in that one class said the lung is the mother of the kidney, and I don't know about the spleen. I'm not an acupuncturist. So it could be the heart is the mother of the spleen. Spleen is the mother of the lung. The lung is the mother. Lung is the mother of the kidney. That was what she said. The lung is the mother of the kidney. Kevin, if you'll write that, whoa, where'd that go? If you'll write that down, I'll put it in the advance because we actually got to balancing the meridians in the advanced, and it's easier than having to do pulse diagnosis. So if you have to have the skill to feel pulses, and American trained acupuncturists aren't usually trained to do pulse diagnosis, or they're not usually very skilled at it. We'll write that down and pass it along. Heart is the mother of the spleen. Spleen is the mother of the lung. The lung is the mother of the kidney. That's an interesting and different. That's pretty cool. I like that. C-section adhesions go in many places. I don't even have to do a whole episode on it. We've got 3 minutes left. So if somebody's had one C-section or more, the challenge that we have, the scar that everybody worries about, is the superficial one, and that is going to be not just skin, it's sclerosis in the adipose underneath, and then scarring in the connective tissue. You can also try 58 in the connective tissue, so for degeneration in the connective tissue underneath the skin. Then think about the peritoneum, and that is also connective tissue or fascia. Actually, it's a specialized kind of fascia. But the other thing with a C-section is there's one person, usually it's one person, depends on how much of a hurry they're in, how much of an emergency it was. If it's a planned C-section, goes a little smoother. If it's an emergency C-section, that's all bets are about off. But there's still one person whose job it is to vacuum up the blood. So as they're going in, there are little bleeders that they cut, and they snip them off or cauterize them. And there's somebody there that's vacuuming. So irrigating and vacuuming, putting water in and vacuuming the blood out. And they miss some. So the other challenge with C-sections is that everything can be glued to everything. So you've got the sigmoid glued to the ovary, glued to the tube, glued to the bladder, glued to the uterus. The other side you can have, and it just depends on how many surgeons there were. If it's a planned C-section, there's usually 2. If it's an emergency C-section, there still might be 2. But on the left side, you can have the cecum, the appendix, the ascending colon glued to the omentum. That's the other thing. The omentum gets sclerosed, glued to the ovary, glued to the tube, glued to the bladder, because the bladder is superficial to the uterus. And that can get glued to the basic rule of thumb with a C-section or any abdominal surgery is anything can be scarred to anything. And your task is to put your hands gently on the abdomen, and the first thing you treat is scarring in the vagus. The vagus is a pain nerve in the abdomen. Creepy your fingers along superficial in the abdomen and treat scarring in the vagus, and then get down and start to treat the scarring between the different organs. How do you identify that? You find something that's stiff, and then you hallucinate or imagine what organ is that, try and identify it, and treat scarring between that organ and whatever it's glued to. And that's a project. And then maybe I'll do a webinar on that. It is tricky because every abdominal adhesion case that you treat is going to be different. And so I'd like to use one model, but the next person you treat is going to be different than the model that I demonstrate on. And then the next one is going to be different than that. She had a C-section, but did she also have endometriosis? Did she also have ruptured ovarian cysts? Did she also have appendicitis? Did she also have irritable bowel? Yikes. there's that. 24 hertz removes scarring. Does 124 remove scarring from torn and broken? Not as far as I can tell. 124 seems to repair connective tissue somehow and repair tendons somehow. Diana Cross has a model for that she presented, I think, in 17 and 18, I think. And that is that somehow 124 creates or stimulates the portion of the cell that creates the output, the microRNA. So there's messenger RNA and microRNA, and the microRNA is what produces a cellular response. Somehow 124 repairs connective tissue. It doesn't do anything for scarring. I'm not sure how you have scarring and torn or broken in the same place. So you can have a tendon, let's say the infraspinatus, one of the teres or both of the teres, injured. And before you fix them, that's why we do the supine shoulder. Before you fix them, you still have to take the scarring out of the subscapular nerve, and the lat, and then you can treat torn and broken in the tendon and labrum, and the supraspinatus and inflammation in the bursa. Ribosomes produces the proteins. You and Diana Cross can do that, have that conversation out. What I remember from her is the messenger RNA leads to microRNA, and there may be ribosomes in there someplace, and I just forgot about them because microRNA was such a new concept for me. So I'll go back and look at her lecture, and I recommend that you do that too. She's the one that put together that theory. And it's 4 minutes after 4. How is it that I talked for an hour? And you asked great questions. Leaf said, I still find better conduction with slightly salty water on the towels. Yeah, tap water is what we use on our towels, and it's pretty salty, at least as it comes out of the tap. Next week, I think Kim will be back. We will be here next week. We have a core seminar on Sunday, Monday, Tuesday, and then Wednesday off, and then Thursday and Friday. And by the way, just so everybody knows, this is the last seminar ever where we will let non-practitioners take the seminar or the practicums live. You can take them on non-practitioners or people without a license or training to touch. So we have better than 60% of the class doesn't have a license to touch, and we actually can't figure out how we're going to do the practicums because there's maybe 6 people out of 15 that have a license to touch. So we'll figure that out, but we're not going to do this again. And I guess that's it. So I will see you next Wednesday. And as far as I know, Kim will be back. So I hope you have a good weekend. Thanks for coming with us. Do good things and enjoy yourselves. And I don't know, saves lives, change the world, the usual thing. Take care. Bye.
The Frequency Specific Microcurrent podcast has been produced by Frequency Specific Seminars for entertainment, educational, and information purposes only. The information and opinion provided in the podcast are not medical advice, do not create any type of doctor-patient relationship, and unless expressly stated, do not reflect the opinions of its affiliates, subsidiaries, or sponsors, or the hosts, or any of the podcast guests or affiliated professional organizations. No person should act or refrain from acting on the basis of the content provided in any podcast without first seeking appropriate medical advice and counseling. No information provided in any podcast should be used as a substitute for personalized medical advice and counseling. FSS expressly disclaims any and all liability relating to any actions taken or not taken based on or any contents of this podcast.